So we're going to talk about assessment. What I'm going to try to do is try to simplify this a little bit. When we look at your national exam, right, the written portion is broken up over the 6 modules. So that second module is that entire assessment module. So each module makes up about 12 to 15% of the questions. And we find that, in your psychomotor exam, right, you have your skills and then you have 2 assessment stations. So you have a medical assessment and a trauma assessment. And we find that students struggle a lot with the assessments because there's a lot of talking points in it. So for your psychomotor exam, they make it very easy, right? When you walk into trauma assessment, you're walking in and you're going to do a trauma assessment on a trauma patient in that testing station, right? When you walk into medical, you know that you're walking in and you're going to have a medical patient. In real life, it's not that simple because we don't know what we're walking into. We have to do an assessment. We're not walking in and being like, this is a trauma patient, this is a medical patient. And even if we are showing up to a trauma scene or somebody who's complaining of a medical complaint, there can be both, right? So we could have somebody who has a syncopal episode and we have a medical problem that caused them to now have this loss of consciousness that resulted in them having a fall. So now maybe they have a head strike, or they fell down a flight of stairs, or they hit their head on something as they went down, they broke a bone, they fractured their pelvis. So now we can have both, right? We can have a motor vehicle accident, or maybe somebody had a seizure, or they had suffered from hypoglycemia, and now, had an altered mental state that contributed now to the car accident, and we're showing up and trying to figure out, which is which. When it comes to assessments, the best tool that we have as a healthcare provider is your assessment. You never ever as a team lead ever delegate your assessment. You do your own assessment. And you want to make sure that you have a good systematic approach to every patient. Okay? Once you get comfortable, assessments are very fluid. The questions that we ask and how we do things are mnemonics. Those in the beginning you have to kind of memorize because you're trying to figure out the system. Once you know what information you need, you can kind of jump around. When we start getting to our history and our sample and our OPQ, you can start to jump around there because it's going to be a fluid conversation back and forth, right? When we have a patient who's unresponsive, they're not able to give us any information, so we have to be able to go through systematically and not miss anything. And the same when you show up and you have a patient who's really sick or really injured, you've got a multi-system trauma patient, learning this assessment helps us prioritize what do we need to take care of first, what has to happen on scene, and what else do we need to now wait until we get in the back of the ambulance while we're on the way to the hospital. So that's where this assessment becomes really important. For your psychomotor exam, the medical assessment, they're looking at, do you know your medications, right? So you're going to get a scenario where you have a patient who's alert and talking to you, who's able to answer your questions, and they're going to watch you go down this OPQRST and this sample history. Are you going to be able to recognize these symptoms, follow your protocol, pick the correct medication, and administer it correctly, letting the patient know how they're going to feel, their side effects, recognizing what improvements we should see if this medication is working, how long until we could re-administer, getting vital signs. All of those things now are going to be part of that medical assessment for the psychomotor. Trauma, when you walk into that patient, is an unresponsive patient. The patient's not going to be able to give you any feedback. You have to be able to go through body system by body system. So, you can watch the trauma assessment video and you can watch the medical assessment videos to see how to do that for the psychomotor. What we're going to do now is we're going to look at kind of this parts of an assessment. The nice thing about assessment is the way that we teach you in EMT school, the way you do it in paramedic school, the way you do it when you're a nurse, when you're a doctor, when you're a surgeon, everybody does the same assessment. The only thing that changes is the interventions that we can do. Okay? So the assessment, the foundation is the exact same. Everybody learns it the same way, everyone does it the same way, and it has to be done. When we look at the initial part of this, our primary assessment, which we'll go over, it has to be done in that order. A, B, C has to be done in that order like we talked about. If we don't fix A, it doesn't matter if we do anything for B. If A isn't managed, B can't work. So when we look at how we break down an assessment, the first part of the assessment is what we call our scene survey. So this is where now you're looking at, scene safety PSI, right? Universal, when you show up, what are we doing? And this now, the scene survey isn't just, saying scene safety. That's ongoing. But it starts when we get the call. So as soon as we get this call and we're told, hey, this is what we're going for, you want to start thinking, what are some things that could potentially be unsafe that we might have to, kind of mitigate when we get there? If you're showing up for a motor vehicle accident on the highway, well, do we have police? There's going to be traffic. How are we going to position ourselves to stay safe so that we don't get struck while we're tending to the patient? Is it going to be broken glass? Are we going to need heavy extrication? We're starting to think of these things. As we show up on scene, that's where we start looking at what's the mechanism. So is this a trauma where we have a mechanism of injury? Is it an illness where we have a nature of illness? Is this now, do we have multiple patients? Do we need additional resources? So do we need fire on scene for heavy extrication? Do we need police on scene to help with traffic, or do we have a combative patient or a potential crime scene? Do we need power cut off? Do we need to notify the power company and have them disconnect power? Do we need animal control? So there's lots of different things that we may need for additional resources. Do we need more hands to help carry this patient safely? So now we're looking at what do we need for additional resources. In your psychomotor testing, you kind of ask for them right in the beginning. You're going to see as we start to work, this is where now sometimes right away we know what they are. If I need additional resources, I'm better off activating them and then calling them off if I don't need them than waiting and now being delayed and getting extra help to manage additional patients or a really critical patient. Okay? So now we're looking at those additional resources. We have scene safety, BSI, we're looking at that mechanism or nature of illness, we're looking at do we have a need for additional resources, how many patients do we have, and then we're starting to make a determination, do we need to take spinal precautions? So if we're thinking that this is a trauma, if you find a patient laying on the floor, and I don't know how they got there, I have to kind of take those precautions and then do an assessment and rule out that there is a need for me to maintain them. I can then disengage and I can let go of C-spine if I've ruled out there isn't a need for it. But what I don't want to do is not take them and then find out later that there was a potential that there was a head, neck, back injury and we didn't take spinal precautions. We always err on the side of caution, so we'll come in and we'll take those, start talking to the patient if they're able to answer, check the back of the head, the back of the neck. I'll be able to rule out there no back pain, no neck pain, no, I didn't hit myself, I was lower to the ground. Now I would say, okay, there's no need for us to keep maintaining this immobilization. But we're going to take it until we've ruled it out. You have a patient who's sitting on that couch and it doesn't look like there's been any trauma. We can ask them as we walk in, if they've had any head strikes, if they've hurt, if there's any trauma involved. Maybe they fell down the stairs, but they were able to get up and now they're sitting in a chair. So we still want to ask those questions, but if somebody's sitting in a chair, I'm not going to walk up and immediately take C-spine precautions. So you're going to kind of look at your scene and now start making these determinations. Okay? So once we've done our scene survey, that now puts us at our primary assessment. So when we look at our primary assessment, we do this for every single patient, all right? The purpose of our primary assessment is to find and treat our life threats. All right? Primary assessment, find and treat life threats. As soon as we find a threat, we have to fix it. Okay? So this is where now when we look at that primary assessment, when we come in, it starts with our level of consciousness. So we're now coming in, if I have a patient who's sitting up and talking to me, I'm going to start asking them questions, and I'm going to start to make a determination. Are they alert and oriented to person, place, time, and event? A&O times 4, right? That would be ideal. That's our, they've got a GCS of 15, our Glasgow Coma scale, which we'll talk more about in our vital signs, right? We're looking at that level of consciousness. Are they able to answer these questions appropriately? And you want to ask questions that you know the answer to, right? So we're going to do kind of this check. If I have a patient who, when I walk in, they're not, responsive to me, I find them laying on the ground. As I approach, right, we take our C-spine precaution, hey, can you hear me? I'm checking now verbal. If they don't respond to verbal, I give a little painful stimuli. So we no longer do sternal rubs because if they do have, an injury, thoracic injury, we don't want to do that, and we don't want to start manipulating them. So a little squeeze on the trapezius, just enough to elicit a response. If they don't respond, we say that they're truly unresponsive. So this is where now we're looking at our AVPU scale, right? And this is where this module, we really start looking at all of these mnemonics. So A is for alert, B is for verbal, P is for painful, and U is for unresponsive. So we want to make sure that we're checking this. We do this for every single patient. And this can change. So we can have a patient who's talking to us one second and unresponsive the next. We get a patient who's unresponsive, we start to intervene and they start to wake up. So this can change throughout the course of our time together, all right? So the first part of our primary assessment is that level of consciousness, right? How are they responding to me? Then we go right back into that ABC assessment. So our airway, right? Is it open? Is it patent? Can the patient keep it secure? So if I have a patient who is unresponsive, I'm now looking, if I'm opening with the head tilt chin lift, if there's trauma, the modified jaw thrust, checking to see if it's clear. Do we need to suction? No more than 10 seconds, not losing sight of the distal tip, suctioning on the way out. Secure. OPA, if they're unresponsive and there's no gag reflex, if they are semi-conscious or they have an intact gag reflex, as long as there's no facial trauma, now we can start looking to use the NPA to help secure, prevent that tongue from becoming an occlusion to this airway. So we have to do, this is a complete airway assessment. We have 3 things that we need to do to complete that airway assessment, okay? Then we have our breathing. So the question we're asking in our breathing assessment is it adequate? Okay? Is it adequate? We mean, is it adequate to sustain life? If the answer is no, then we need to ventilate our patient, right? So if they're hypoventilating, if they're hyperventilating, and we're not able to coach them down, then we need to step in and we need to ventilate this patient, all right? We're gonna take over that movement of air. If it is adequate, they're breathing okay, now we're looking at, do we need to make a supplemental oxygen decision? So the way that we answer these questions is now we're looking, so we have to kind of, expose the chest. So if this is a trauma, we may have to remove clothing. Now, if this is a medical and you have a, little, Nana sitting in the chair complaining of some shortness of breath, don't walk in and rip off her shirt and cut it off. That's weird and creepy, right? You're gonna expose, maybe lifting up the back of the shirt to listen with your stethoscope. You're exposing as needed. All right, so this is, if I need to remove clothing in a major trauma to get to something to be able to treat it or to be able to see what we're working with, fine. Otherwise, I'm removing clothing as needed, all right? Once we've exposed it, we're now doing that look, listen, and feel. All right, so with these 3 things now, what we're looking at is inspect. So we use all our big medical words, right? We're going to inspect. The first thing I'm doing is I'm looking, do I have good symmetrical chest rise? Do I have paradoxical motion? Where I have 2 or more ribs broken in 2 or more places, I have a flail segment. So now I have, as the ribs go up and out, I have a segment that's going in the opposite direction. So as the ribs are going out, the broken segment is coming in. And then when the ribs come in, the broken segment goes out. We call that paradoxical. It's moving, in opposite directions of each other. Do I only have one side of the chest that's going up? Do I have any injury? Do I start to see, we'll talk about some of those other mnemonics, but we're looking at, do we have any injury? Anything that I see, do I have bleeding? Do I have any open holes, any sucking wounds? I'm inspecting for this damage. Then I'm going to palpate. All right, so you can watch that in that trauma video. You can see that demonstration. I'm going to knife down the sternal body. I'm putting my hands on the ribs. I may have to put my hands together, my thumbs, right? So now if I put this on the patient, and now during an inspiration and expiration, I should see my hands go out in equal distance. My thumbs, I'm watching my thumbs move apart from putting them on the chest, and I'm trying to get an idea of, do we have good equal chest rise? So we're going to palpate. I'm feeling for any type of crepitus, subcutaneous emphysema, any of these injuries that we have. And then we have our auscultate. So this is our big fancy word for listen, right? So here we're going to use our stethoscope, and we're going to listen in our spaces. And we'll show you how to do this, right, in our vital signs, and we'll practice this in lab. This is where now you're going to listen with your stethoscope, you're going to listen to lung sounds. And what we're doing is we're determining the rate, the rhythm, and the quality of their breathing. How fast or slow? Well, are they breathing 4 times a minute? We know that that is inadequate. We need to ventilate. Okay? Once we've determined this, now we determine, does our patient need oxygen? If they need supplemental oxygen, are we putting them on a non-rebreather? Are we putting them on a nasal cannula? Do we need to ventilate this patient with a BVM? Or are they okay on room air? Have we determined that their breathing is absolutely fine? all right? So now we come in, we've done a complete breathing assessment. We've made our oxygen delivery decision, and this is where we put our patient on oxygen. In your psychomotor exam, critical fail to not put your patient on oxygen, right? So, as we're doing this, not every patient that we come in contact with needs oxygen in real life. You have to do an assessment and be able to make that determination. And then we have C. Under C, C is for circulation. So the three things we're looking at is our pulses. So we're going to check for, on an unresponsive patient, a carotid pulse. If I have a patient who's responsive and sitting and talking to, we'll check a radial pulse. When they're unresponsive, we're going to check for that carotid for a central pulse. At the same time, we're also going to check for radial. We're checking for perfusion. Do we have good blood to the distal extremities? So in an unresponsive, you're going to use your hands and you're going to check for a carotid and a radial at the same time. Are they the same? Do they feel the same? Is one a little more diminished? Is one absent? We don't have a radial pulse. Okay? So we're making this determination here. We're checking for pulses. Then we're checking skin vitals. So we're checking for color, we're checking for temperature, and we're checking for moisture, condition of the skin. So now we're looking, normal healthy is warm, pink, and dry. If we have somebody who's cyanotic, where they look kind of bluish in appearance, right? We know that they're hypoxic, they're kind of yellow, they're jaundiced. Now we know that there's a liver problem. They're starting to turn jaundiced, that yellow color. When we have mottling, we start to see kind of these patches, blotchy patches on the skin. We know that they're hypoperfused. We know that they have poor perfusion. So this is a patient where now we've got to really kind of be aggressive in our management and do a really good assessment to find out what's going on. So we've got a lot of different things. Are they flushed, right? Are they warm? Are they febrile? So now we're looking for these skin vitals. How does my patient feel? Even with patients who have darker pigmentation, this is where now we're looking palms of the hand, soles of the feet. You're looking at the lips, the gums. You're looking at the conjunctiva of the eye, so you can have them pull down the eyelid, and you're looking to see if these look pale, then we know that our patient now is pale. When we look pale, cool, diaphoretic means sweaty. This is where now we're showing signs of shock. And we'll talk more about that. We're going to have a whole lecture just on shock. So now these skin vitals are important, and this is something that I'm able to determine kind of right away. So we have our pulse, our skin vitals, and this is where now the third thing is we're looking for bleeding. Okay? Do I see any outward signs of bleeding? If I have a patient who's unresponsive, I might have to do a quick kind of blind glove sweep to see as I put my hands in and pull them out, do I have blood from the posterior aspect, the back of the patient? If I do, if it's something that's excessive, we may have to roll the patient to be able to manage that. Where they shot in the back and now they've fallen, and now as we put our hands behind, we see that they're bleeding. So now we're going to do this assessment here. Okay? So for each of these things, right, we're inspecting, palpating, and auscultating to determine the rate, rhythm, and quality. So we have our three things. So for all of these, in your testing, this is your critical fail. We follow our alphabet, the next thing that comes is D. So to kind of help us remember, we put this as decision. This is our transport decision. So this is now where, when we come up with our transport decision, if we have a sick or injured patient, we want to minimize our scene time to less than 10 minutes. They need a hospital, right? Our job is to stabilize them, get them to the hospital. This is where now, if they are, a sick, critical, high priority patient, we're making a determination. Is it a high priority patient, low priority patient? Testing, you're going to get high priority patients. If you're not going to test on a low priority, that would be silly. So you get high priority patients. So for testing here, you're going to know this is a high priority patient, and then we're going to start, and what we'll look at next will be, our types of assessment. So when you come in, you've got your scene survey, you have your doorway assessment. As you walk towards the patient, what do you see? Is it a male or female? What's the approximate age? Are they sitting in a position that's showing us signs of distress? Are they in a tripod position for breathing? Are they in the fetal position, for belly pain? As I walk towards them, what am I starting to piece together? This whole scene survey, my doorway impression. Now I come in and I start this primary assessment, find and treat my life threats. Level of consciousness, airway assessment, breathing assessment, circulatory assessment. If at any point in this assessment I have to do an intervention, I have to stop, do that intervention, make sure that it's successful, then I move on to the next step. So this is where you have to memorize and you have to get this down, because this, we have to do on every single patient. What's nice is if I walk into a room and I have a patient sitting and talking to me, hey, how's it going? You know, just not feeling so good, a little under the weather. All right, I sprained my ankle. I now know very quickly, I've done an ABC assessment head. They're talking to me, they're answering questions appropriately, they're talking, so I know the airway's open, is patent, there's no gurgling, I don't have to do any intervention. They're alert, so I don't need to secure it, they're able to protect their own airway. Breathing, they're talking in full sentences, I don't see any accessory muscle use, there's no signs of distress. So now, you know, there's no need for me to take over ventilation, and this time it's not apparent that they need any supplemental oxygen. We've checked off on breathing. I'm looking at the patient, I can see their skin vitals. As I introduce myself, you know, they shake my hand, I can feel if they're sweaty. I can do a quick pulse check, right? We have that consent. You're all right if I check your pulse, we do a quick pulse check. And now we've done an ABC assessment, and we know that right now, there's no threats, immediate threats that we need to address. We can move on, and that's going to be the next piece that we're going to look at. How was that?